Thank you, Christian. It's a pleasure to be part of this meeting and to chair the second part of this multiparametric ultrasound. And after excessive cover of these methods for diffuse liver, now we go to the focal liver lesion, which are quite frequent in our practice. And we are very happy to have here again a very good system for the diagnosis and for the decision of treatment. And the first presenter will be Dietrich, that is a German working now in Switzerland. He's very well known. He's the author of many papers of very good value of guideline. And the topic for today for Christoph will be incidental focal liver lesion. Contrast makes the difference. Please, Christoph, you is the only person that can speak wonderful about all the type of image that we including the very difficult lesion like the adenoma. Please, Christoph, we are very interested about your presentation.
Dear Professor Sporea, dear Johan, ladies and gentlemen, I'm more than happy to be allowed to present in this FSUMP webinar on incidental focal liver lesions. Contrast makes the difference. Have a look. The content of my lecture will be to talk about incidental findings, focal liver lesions, autopsy and imaging studies, the prevalence of such lesions, and it will be in the center of my talk. CIUS makes the difference. The idea came 2011 or even earlier. Der zufällig entdeckte Leber-Rundherd, focal liver lesion incidental findings, together with Christian Jensen, chairing the first part of this webinar, we came to the idea to think about on how to manage incidental findings. And we also published in English a little later, pretty much the same. And Professor Johan Sporea and Professor Roxana Sirli and the Romanian team is currently working on incidental findings according to a VFUMP project. It is more than sophisticated guidelines dealing with contrast-enhanced ultrasound in elastography. The idea by clinical workup of incidental findings for our 55,000 VFUMP members to deal with the management of focal liver lesions. And we have published the idea of this VFUMP project a year ago and published already papers on adrenal gland tumors, on splenic tumors, on testicular tumors and other organ manifestation. The first question is about the prevalence. So if we would be asked how frequent are focal liver lesions, I would say, let's say 5%, almost or the most are hemangioma, 1% are focal nodular hyperplasia, and 1/10 of focal nodular hyperplasia are hepatocellular adenoma. So those three prevalences would be a good idea to take home as message, as take-home message. Second question is a patient at risk. A patient at risk is a patient with a malignant underlying disease or liver cirrhosis. And an incidental finding with or without history of malignant disease would be benign in more than 99% if the patient has no symptoms, no pathological laboratory data, and there is no history of malignant disease. And if a patient has a malignant disease past medical history, Then if you find incidental focal liver lesion, the probability is about 50% to be benign or malignant. And then we have also to think about the potential of malignant transformation. Incidental findings, patient at risk liver cirrhosis is classified according to liver imaging reporting and data system, and a few ideas at the end of the lecture. Third question is if the lesion is benign or malignant, the prognosis. We will talk a little bit about that. CEOs makes the difference. It's all about how to perform contrast enhanced ultrasound. If you are interested, open access journal, all the authors who presented here have given their experience into that. Most benign lesions are hyper-enhancing in the arterial and liver-specific portal venous and late phase in comparison to the surrounding liver parenchyma, and there is no need of biopsy if they show arterial phase hyper-enhancement and portal venous and sinusoid hyper-enhancement. Look here. Central arterial blood supply and hyper-enhancing in the portal venous phase. You can identify the portal vein right on here, and in all phases later on. Then this lesion cannot be malignant. It is benign. It is a lying detector, the portal venous and late phase. If that shows wash out, arterial phase hyper-enhancement and wash out, then it could be a malignant focal liver lesion or inflammatory. At least we have to clarify the diagnosis. Here you can see an arterial phase hyper-enhancing lesion in comparison to the portal vein. It's the arterial phase and the portal vein is not enhancing during this moment. Can you see it? Hepatic artery, portal vein. A few seconds later, the lesion is hypo-enhancing and the portal vein is enhancing. No, vice versa. The portal vein is enhancing and therefore the lesion is hypo-enhancing, showing wash out. A little later, punched out, wash out. It's a malignant lesion in comparison to the portal vein. Here you can see the lesion is hyper-enhancing, orange. Portal vein is not enhancing. Not enhancing. Right now it's enhancing during this moment. During this moment, the lesion shows wash out. Within a few seconds, you will never see that by using computer tomography and magnetic resonance imaging. You can see clearly the moment of hypo-enhancement wash out. Hyper-enhancing, orange, blue, hypo-enhancing. Portal vein is enhancing right now. The lesion is hypo-enhancing, showing blue color. Dynamic vascular pattern shows clearly the moment of wash out. We can use it. I thought it would be a good spoke wheel appearance of a focal nodular hyperplasia. No, not at all. It's a typical image of sarcoma, and the lady was referred for surgery, but only shown by contrast enhanced ultrasound. You see the detection of multiple metastatic disease within all other liver segments, and this young lady couldn't be operated in the due to the sarcoma. We have also incidental findings. It was a real incidental finding during ultrasound course. You see the cyst, there are nodules, and we are interested if this cystic lesion is a neoplasia or a cyst. Injecting 0.6 ml of Sonovil, you can see the nodules. They are enhancing, hyper-enhancing during all phases. It is a cyst adenoma with a potential of malignant transformation. It's not my topic, but we might discuss it a little later. I refer to the guidelines published 2020 from WIFUMB and EFSUMB for the guidelines and good clinical practice recommendations for contrast-enhanced ultrasound for more details. It has been published in the European Journal of Ultrasound, Ultraschallende Medizin, and the Ultrasound Medicine Biology, the WIFUMB journal. CEOS is recommended as a first-line imaging technique for the characterization of incidentally detected indeterminate focal liver lesion at ultrasound in patients with non-cirrhotic liver and without a history of clinical suspicion of malignancy. There is a high level of evidence and a strong recommendation. CEOS is recommended for the characterization of focal liver lesion in the non-cirrhotic liver in patients with inconclusive findings at CT or MRI imaging. Also, high level of evidence and strong recommendation. I do not talk at all about typical cysts and calcifications during my presentation right now. Hemangioma, we have 6 types. The typical and the atypical with complete or incomplete centripetal fill-in. The atypical regressive changes with totally thrombosed hemangioma, not enhancing at all, giant hemangioma, shunt hemangioma, infantile hemangioma. Caveat, there are pitfalls. Hemangioma, not typical, next to the right liver vein, hyper-enhancing in all phases, could only be a benign lesion. It is a hemangioma. Giant hemangioma could be benign or malignant. The lesion shown here. CEOS makes the difference. You can see peripheral nodular contrast enhancement, centripetal fill-in, hyper-enhancing during all phases. It's a giant hemangioma, a typical giant hemangioma. In up to 30%, hemangioma are in combination with other focal liver lesion. Here you can see CEOS makes the difference. I'm not quite sure what is here. It is a focal nodular hyperplasia and a hemangioma with peripherally nodular contrast enhancement and centripetal fill-in. Here you can find a shunt hemangioma, injecting Sonoview in a focal fatty sparing. In the center, you can see hyper-enhancing, enhancing, arterial phase enhancing, and here you can see these shunts in the surrounding. Therefore, we call it a shunt hemangioma because it contains shunt in the surrounding, explaining the focal fatty sparing with mostly oxygen arterial phase supply. Here you can see the entire lesion and hyper-enhancing during all phases. Caveat, there are lesions looking like peripheral nodular contrast enhancement, like here, but it shows wash out. It is hemangioendothelioma. So in the portal venous phase, the line detector tells us this we have there's a need for biopsy and histological examination. There are pitfalls, for sure. If you are interested in that entity, go to the World Journal of Gastroenterology with a pretty large number of examinations. And this is an infantile hemangioma. We published in a paper on pediatric lesions. So I've shown you 5 out of 6 hemangioma. The thrombose doesn't enhance and at all. All this focal liver lesion in pediatric patients have been recently published in a paper by EFSUMB, Pediatric Registry Working Group. If you are interested, there are all information for the pediatric group. Focal nodular hyperplasia, let's talk about 4 types. A central arterial supplying lesion, you can see here, you can see here, you can see here, you can see here, the central artery. You can see the central artery might be eccentric, asymmetric, like shown here. Third one is multiple vascular supply in a large lesion as shown here. And the fourth type is homogeneous hyperenhancement early and hyperenhancing during all phases. Focal nodular hyperplasia does contain portal vein branches, atypical, and sinusoids, and it is therefore hyperenhancing in 96% of patients as a typical sign of FNH. If you see hypoenhancing focal nodular hyperplasia, be aware of a pitfall, bubble destruction in the near field. We have also a technique that we might have the timeline in our image. Here you can see a pretty nice focal nodular hyperplasia, central arterial blood supply, pretty nice, but it can be even better. We can inject and have the timeline in our image, yellow, green, blue, lila, and therefore we can see the enhancement pattern parametric, the time intensity curve analysis behind quite nicely in one image. The adenoma should be classified according to molecular classification. It is called HNF, hepatic nuclear factor 1 alpha inactivated, beta-catenin activated, inflammatory with or without fat content, and the inflammatory respective non-inflammatory adenoma. Here you can see it's not hemangioma because it contains vessels within the lesion. It's a typical beta-catenin activated HCA in glycogenosis disease. Here you can see a hypoechoic and fatty liver. It's an HNF1 alpha inactivated, histologically proven adenoma. You can see the typical small adenoma you might never see because it looks like normal liver. In Niemann-Pick disease, arterial phase hyperenhancing. It does not contain portal vein branches and therefore it shows wash out, hypoenhancement. If you are more interested, we have published a paper on hepatocellular adenoma, and here you can see inflammatory hepatocellular adenoma, which has been often confused in the past with focal nodular hyperplasia and multilocular arterial phase hyperenhancement. If CUS has definitely characterized a benign focal liver lesion, further investigations are not anymore recommended to confirm the diagnosis because it's clear hyperenhancement in all phases. CUS can be used to monitor changes in enhancement patterns of focal liver lesions requiring a follow-up. Here you can see a lesion which shows hyperenhancement and imatinib treatment in gastrointestinal stroma tumor a few months later, 3 months later. It does not show hyperenhancement. It shows no enhancement at all. It was very good treated medically, but it has still a response evaluation criteria in solid tumors. It showed a mass-like lesion, but not enhancing anymore, whereas it was enhancing 3 months earlier. So we learn that contrast-enhanced ultrasound allows us to evaluate treatment response. Most benign lesions are hyperenhancing in the portal venous and late phase in comparison to the surrounding liver parenchyma. No biopsy is necessary in hemangioma and FNH. In patient at risk, we have a totally different algorithm, liver imaging reporting data system, to use a proper technique, to have quality assurance, to have a consistent terminology, a clear communication to educate people and contribute to optimal management. And the CUS LIRATS group is shown here, but it is not topic of this talk. I refer also to many other focal liver lesions. We are working worldwide right now on a very rare focal liver lesion. If you have some, please send it to me. The very rare, even we do not know the name. We are collecting those data currently. And coming to conclusion, we have talked about incidental findings. We know about the prevalence, the 5% rule, and CIOS makes a difference to differentiate between the benign and the malignant ones. Thank you so much for your attention. I'm looking forward for an exciting discussion.